Okay, well, it's the 2 o'clock hour. Why don't we go ahead and get started? I'll just introduce Grant. It's not in the script, but I'll just say this is Grant Kleindinst. He's going to give us some opening words. Thank you.
Good afternoon and welcome to the Indiana ALS Association's ALS Today and Tomorrow webinar. My name is Grant Kleindinst and I am the Rehab Product Specialist for Quantum Rehab, and I will serve as your host today. Quantum is a proud education sponsor for the series. We are passionate about serving the ALS community and are longtime partners with the Indiana chapter. Currently at Quantum, we have and will be releasing some multiple products this year, including our new front-wheel drive wheelchair and our Forefront HD. In addition, we'll be releasing a new heavy-duty Group 2 power wheelchair that have tilt, and that will be our J4 HD. Lastly, we are excited also to release our brand new TB4 seating system that will include interior tilt and up to 8 memory seat positions. These features and products will help provide patients of Indiana a variety of options to meet their medical needs. But now it's my pleasure to introduce our featured speaker for today's webinar about respiratory challenges and options in ALS. Cynthia Knoche is the Director of Chapter Care Services with the ALS Association. She's also been a respiratory therapist since 1979 with acute hospital and home care experience. She supports ALS chapters across the association network aligned with care services and programming. Just a bit of housekeeping before Cynthia begins to speak. Please feel free to ask questions throughout her presentation in the chat box. We will facilitate Q&A after she speaks, but we'll monitor the chat feature throughout our time together. So please join me in welcoming Cynthia.
Thanks so much, Connie and Grant. Let me see if I can share my slides with you and the audience today. There we go. I certainly appreciate you inviting me to share this information during your virtual symposium format. We're going to be speaking today on respiratory challenges and options. I have just a few disclosures. If I do mention any equipment brands, they are mentioned just as an example, but certainly not an endorsement of a specific product or service. So let's take a high-level view of what we're going to be talking about today. Really, the respiratory challenges.
Cynthia,
Yes.
I'm sorry, on my screen, it's not showing the share screen.
Well, that's not good.
Yeah, Grant, do you see it? Okay. There looks like it's pulling up. There you go.
That looks much better.
Apologies.
Thank you. That's why we have webinar wizards to assist us. So I can quickly go by my disclosure screen and highlight what we're going to be talking about today. Really, respiratory challenges, how they impact people with ALS, and more importantly, what our options are so that we can address these challenges. I can tell you that there are really 3 points to focus on. One is always decreasing the work of breathing. Very importantly, maintaining a clear airway, and all of that supports maximizing quality of life. So let's take a quick overview of what ALS is in case there are some newer folks on the audience with us. Symptom onset tends to be limb onset, affecting the hands or feet. Bulbar onset, impacting swallowing or speaking abilities, and then really less frequently respiratory onset. We see most people have a limb or bulbar onset, but that said, during the journey as that unfolds, most people will experience respiratory challenges. And how does ALS impact the respiratory system? The reality is the lungs, the pulmonary function of the lungs themselves tend to work well. It's just that those respiratory muscles become weakened and really inhibit a person's ability to take in an adequate amount of air with each breath, in addition to taking in an adequate amount of air, very importantly, is being able to clear your airway or cough and make sure you expel anything that may have gotten down there. I can tell you that every respiratory therapist, pulmonary physician, and ALS multidisciplinary team member are going to focus on decreasing your work of breathing. We know that ALS is a disease that impacts your energy. So we want to make sure that we economize our use of energy. And a good way to do that is to decrease your work of breathing. Let's pause for just a minute to take a look at the difference between respiration and ventilation, because these are really terms that mean two different things, and sometimes they're used interchangeably. Respiration actually means a gas moving across a membrane. For example, you take a breath of air in and the oxygen goes from your lungs into your bloodstream. Then it circulates around your body, it gets to your big toe and leaves from the capillary system of your great toe into your tissues. That's respiration, the oxygen moving across the membrane. Ventilation is literally air moving in and out. We burn something on the stove, so we open up our windows and doors to ventilate the kitchen. We're driving in the car, open up the windows to ventilate the car. It's simply air moving in and out. And this is the real issue people with ALS seem to have. It's not necessarily an issue with the lungs not working, but it's an issue with the ventilation, getting an adequate amount of air in and out of the lungs. That's why people with ALS tend to need support with the ventilation, or rather than respiratory support, ventilation support. Oftentimes that is shown in the form of non-invasive ventilatory support. You may have heard of a BiPAP or a bi-level machine or non-invasive ventilation. And what this is with the use of a mask that covers your nose or your mouth, or your nose and your mouth, it provides increased ventilation so that when you initiate a breath, it's easier to fill your lungs with air, and then you're able to exhale passively. Invasive respiratory support is something a little bit different, and that actually involves a tracheostomy or a surgical incision to your neck so that the mechanical ventilation can deliver adequate amount of ventilation directly to your airway. I do want to make sure that we're aware that the use of ventilation support does not stop the progression of ALS. It does support adequate ventilation and adds to quality of life, but it does not stop the overall progression of the disease. Let's look at how your respiratory status is evaluated when you go to clinic. I'm sure when you go to clinic every 3 or 4 months, the respiratory therapist stops by to see you, and they may do several different tests. And FVC, or forced vital capacity, is a measurement of how much air you're able to exhale after you've taken the deepest breath possible. A PaCO2 is actually a blood test where we can measure the amount of carbon dioxide in your blood. As your ventilatory status decreases, the CO2 levels in your blood will increase. Another test is an MIP, maximal inspiratory pressure. That's a test that uses equipment like this in the upper right-hand corner to measure the strength of your inspiratory muscles. So they ask you to take a deep breath, and then they block the airway. So you're essentially measuring the amount of negative pressure or sucking force your inspiratory muscles can exert. There is a difference between having these tests done sitting or supine, laying down. And I mention this because it's really extremely important for people to be able to access respiratory and ventilatory support as soon as possible in the ALS journey. And as you can imagine, if you're sitting up in a chair and you have support of your arms, it's a little bit easier to take a deep breath than if you're laying down flat or supine. So we try to make sure that the FVCs are done in the sitting position versus the supine position. It just gives us a better indication of your overall ventilatory status, and oftentimes enables you to qualify for that equipment earlier. On the screen are several different examples of ventilation support. ResMed, Philips Respironics, Ventec Life are just three manufacturers. There are others that provide different types of equipment. The bi-level or BiPAP support is not designed to be a life support piece of equipment. It's equipment that's utilized with a nasal mask, a oral mask, or a hybrid mask. And when you take a breath, the machine is designed to click on and provide you with an enhanced inspiratory volume. So while you may only have enough energy to take in, a quarter or a half a cup of air, when you're using a bi-level or BiPAP machine, when you make that initial inspiratory effort, the machine can give you a cup of air or a pint of air. So again, you're using less energy than still getting the ventilation that you need. In addition to bi-level support, which is typically used part-time, oftentimes when people are sleeping, or increased use during the day, multifunction ventilators are also available. These pieces of equipment are a little bit larger. They tend to be the size of, say, a lunchbox, a good-sized lunchbox, a lunchbox that a teenager may need. I know teenagers eat a lot, so a little bit larger lunchbox. But all of these are portable. They have operate with batteries, so you're not tethered to your electrical cord in your home. These multifunction ventilators can provide all of the support that a bi-level type unit can provide. They're also designed to be life support devices, and they can all be used with mask ventilation or with invasive tracheostomy ventilation. Let's take a look at the types of masks that are used. It's usually termed a mask or an interface, and I can tell you size does matter. It's really important to get a good fit on that mask, because after all, you're relying on the mask and the equipment to provide your ventilatory support. Sometimes people use one style of mask at night, for example, a full face mask like this, and then if they're using their machine during the day, they don't really want that mask over their nose and their mouth. Maybe this prevents them from using their glasses, so they're not able to read or watch television. So they may go to a different type mask for use during the day. In addition, I do want to mention that people with ALS tend to lose weight over the course of the journey with this disease. And unfortunately, when we lose weight, that tends to leave from our face. You know, when we gain weight, it always comes to our hips first, but when we lose weight, it leaves from our face. And as you lose weight, even if it's 15 or 20 pounds, you can anticipate that you may need a different size mask or the adjustment for that mask. So if you're using bi-level support while you're ALS, please don't hesitate to connect with your respiratory therapist or home care company to ensure that your mask is fitting properly, or that you may need more than one mask if you're using it with increased frequency, for example, during the day or as well as nighttime. This is another type of access or interface. It's mouthpiece ventilation. Oftentimes, people with ALS use their device at night, a bi-level device particularly, but during the day, again, they don't want to have that mask over their nose and mouth. It impedes the quality of life and their ability to do other things, eating, watching television, maybe reading the paper if they use glasses. These mouthpiece ventilation are two types of interfaces that are used with non-invasive ventilators that enable a person to simply close their lips around this mouthpiece. And when they do that, that slight pressure around that mouthpiece triggers the unit to fill your lungs with air. Again, this is oftentimes used in conjunction with people that utilize a respiratory support at night as well, mouthpiece ventilation. Invasive ventilation. And I do not see the chat box, so I don't see any questions that are coming through. I believe Connie and Grant will keep me apprised of that. Invasive ventilation. Because ALS is a progressive disease, we can anticipate that our respiratory muscles will become weaker over time. We don't know what the timing of that is, but we anticipate that the muscles will become weaker as the disease progresses. At some point, non-invasive ventilation may not be adequate to sustain your physiology and your quality of life. So the next thought would be invasive ventilation, which requires a tracheostomy or a surgical incision into the neck. Now, many people are quite surprised by this, and a lot of folks don't want to even think about it because it's not something we see every day. Most people don't know anybody else that has a tracheostomy, but I want to share with you that thousands of people have tracheostomies, and it is surgical incision that allows the equipment to be connected directly to your airway. That decreases your work of breathing a number of ways. Number one, you don't have to worry about air going through your nose and your mouth because it's no longer goes directly into your airway. The second thing is oftentimes people are challenged with choking or aspiration issues, and it's frightening for the people that are diagnosed with ALS or even their families. And if that's a major issue, then a tracheostomy may be a potential solution for you to avoid that risk of aspiration, increased secretion, sialorrhea. You can see these are two people with ALS. This gentleman here actually lives in a SNF or assisted living facility, and he has a portable ventilator, one of the ones I showed you earlier, that is connected directly to his tracheostomy. And his sons have now taken him out to a ball game. This photo was taken just before the close of the public health emergency with COVID-19. But you can see here that it's battery operated and enabled him to go to a baseball game. This is a gentleman who's using it at home. And of course, you can see the communication device that he is using along with his caregiver. So again, two examples of people that can use tracheostomy ventilation. It certainly does address several issues related to ventilation and adequate ventilation, but they in themselves have their own pros and cons. Let's take a look at those. Well, invasive ventilation certainly does improve your oxygen and carbon dioxide level because it manages the ventilation for you. It decreases the work of breathing because you're relying on a piece of equipment, again, about the size of a lunchbox, to do that breathing for you so you don't have to spend any of your energy breathing. Research studies have shown that it does improve the sleep quality of people that have ALS, and it does improve their quality of life. But as many things, double-edged sword, there are some disadvantages. There are some potential complications of long-term dependence on artificial airway and life support. The cost of care can be high. Medicare and most other insurance will cover the cost of a ventilator and the equipment that you need to use the ventilator, but they don't cover the cost of a person providing care for you. As you can imagine, someone that is using invasive ventilation really needs to have a 24-hour caregiver. Oftentimes, as people are approaching the need for full-time ventilation, they already do have a 24-hour caregiver. But it's interesting to note that with regard to tracheostomy ventilation, absolutely having a caregiver there 24 hours a day would be required. And we know that one person can't provide 24-hour-a-day care. So it's multiple caregivers. Interestingly as well, while people diagnosed with ALS report an increased quality of life with tracheostomy ventilation, when their caregivers were surveyed, the caregivers reported that their own quality of life did decrease, and that may be due to the significant amount of care that's required. Here again, you can see two people that are using invasive ventilation. And again, with regard to the portability of equipment, it certainly does support your quality of life to be in the community with the associated equipment, such as a power wheelchair or communication device. This person is using the equipment in their home and using a rapid access communication. One thing that's really important with regard to whatever type of respiratory or ventilatory support you decide you want to take advantage of is making sure you monitor and manage the respiratory equipment and your response to it. ALS is a progressive disease, so we anticipate that your body is going to be changing, and that may dictate changes needed in the equipment. It could be the inspiratory pressure, the expiratory pressure. It could be the sensitivity that triggers or cycles the equipment. There are a lot of different things that are involved with setting up a bi-level or non-invasive ventilator, and that's why you need the expertise of your respiratory therapist, both in the clinic and your home care respiratory therapist. We do know that downloading the equipment provides us with some key information, perhaps that we can anticipate seeing things ahead of time or trends and make those adjustments early so that you can take advantage of the equipment and how it works. I've been talking about ventilation, and earlier I mentioned how important airway clearance was. Now, we know one of the challenges with ALS is the inability to take in an adequate breath. Just because our muscles are so weak, we don't have the ability to take in a deep breath. But think about it, airway clearance is incredibly. We know that most people cough multiple times a day without even thinking about it. But when you stop and think about it, right now, cough. Interestingly, when we hear the word cough, we always think about an outburst or a noise. But the reality is the first stage or phase of a cough is taking in a deep breath. If you're not able to take in a deep breath, you're not going to be able to cough adequately. And the key phrase here is adequately, maintaining an adequate cough. It's very important to be able to take a deep enough breath so that you have the force to provide an adequate cough. One of the reasons that people are unable to take a deep breath, in addition to weak respiratory muscles, are the bulbar component of ALS, whereby the muscles in the throat become a little bit flaccid and you don't have quite control over your throat muscles. So it's a little bit difficult to take in a deep breath. Close your glottis or your vocal cords closed to increase the pressure before you cough out or expel your cough. But again, very important because we don't want anything to get down into our lungs that shouldn't be there. We don't want food or drink to go down the wrong pipe. During your time at the clinic, your respiratory therapist may actually do a respiratory evaluation that can help in evaluating your ability to clear your airway, and that's the peak cough flow. You can see here that these are just two types of pieces of equipment. A peak cough flow meter can be used with the mouthpiece or a mask, and we do know that there are certain parameters whereby if your peak cough flow or the force of air coming out after you've taken in a full deep breath and tried to cough out is low, we know that those some issues, and we want to help you with that cough. There are several ways that we can help you do that. Some of that is glossopharyngeal breathing, breath stacking, or mechanical cough assistance device. So these are three different types of cough assistance. Hillrom has a vital cough, Philips has a cough assist, which are pieces of equipment that simulate a cough. So when you turn these equipment on with that mask, you trigger the inhalation, the equipment provides a good full breath and then automatically switches from positive pressure to negative pressure to help pull any items or your airway up, just like you would if you were coughing. So it really a typical cough. Another way to do that is yourself. This person is actually doing it on their own. They can have an assistant. This is called a bag mask valve. This is the bag. A mask, he's using a mouthpiece instead of a mask. And this is the valve here. So this person is able to squeeze a bag that looks like a football, increase the amount of air going into his lungs, and he can do this 2 or 3 times without exhaling if he has control of his glottis. So you can imagine you take in a pint of air without exhaling, and then another pint without exhaling, and then another pint, and soon you have a full volume of air, and then you're able to cough. That increases the amount of air, the volume in your lungs prior to coughing, and we find that's quite helpful. A number of folks report that secretions are a huge problem in ALS. And of course, if you're not able to swallow safely or swallow without things going down the wrong pipe, increased secretions can be a problem. We don't want those secretions going down the wrong pipe into your lungs or you aspirating those secretions. There are several things that can address the secretions, and the multidisciplinary teams tells me that it's not your body creating more secretions. It's more probably that you're noticing it more, and because you're not able to swallow those automatically without thinking about it, those secretions may tend to pool up in your mouth. Medications can be prescribed to decrease the amount of secretions your body produces. If secretions are a unbearably huge problem for you, two other methods have been used to address, again, significant issues with secretions. Electron beam therapy, radiotherapy actually targets the salivary glands to decrease the amount of secretions that are provided. And the Botox toxin is actually also used to decrease the amount of secretions your body produces. For some people with huge issues with secretions, and again, we know everyone's journey with ALS is a little bit different. Some folks are able to walk but unable to talk. Other people are unable to talk but are able to walk. For a small subset of folks, they're unable to speak and they have a huge issue with sialorrhea or secretions, which really becomes egregious because it impacts their ability to safely swallow, to eat, and increases their risk of aspiration. An article was published about using a total laryngectomy to address the increased sialorrhea issue that patients with ALS have had. So while this seems like it is an outlandish solution, for these folks that are already not speaking because of the significant impact of the bulbar component of their ALS, but they are experiencing significant issues with potential aspiration, total laryngectomy simply removes their voice box and brings their trachea out to the front of their neck. I actually was able to meet several people that have had this done, and one particular gentleman was actually still working at his family business. He was walking around, but his impact was so great and the sialorrhea was so significant that he had this done at the recommendation of his physician. And it really decreased the anxiety he and his family had with regard to always worrying about choking or things going down the wrong pipe. Again, I'm sharing with you options that may be applicable to a small segment of people. The key here is I want you to understand that there are a wide variety of options to address whatever your situation is. So don't hesitate to explore what your challenges are and what those potential options might be with your healthcare team. I also want to take a few minutes just to review that it's very difficult to address the challenges associated with ALS from a respiratory component in a silo. It's not simply a respiratory therapist addressing your respiratory concerns and the physical therapist addressing your mobility concerns and the dietitian addressing your nutrition concerns. Because ALS is so comprehensive, there's a lot of overlap, and we actually see that oftentimes the physical therapist, nutritionist, or communication SLP can address some of your respiratory issues. Let's take a look at this. I know Grant is with Quantum Rehab on the call, and he can certainly appreciate the importance of appropriate seating and mobility. Not only does that make sure appropriate seating ensure that you have decreased risk of skin breakdown and you're able to have mobility inside and outside your home, we also know that appropriate seating and positioning absolutely can decrease your work of breathing. I saw a patient with ALS that was at clinic with his wife, and his wife said, we have to see the respiratory therapist immediately. My husband's work of breathing has increased and he's so short of breath since his last visit. And this was a very tall gentleman sitting in a wheelchair. He literally borrowed from his Aunt Sadie, and it was a standard wheelchair with a sling bottom. he didn't even have any significant arm support and no support for his feet. So I wasn't surprised that while seating for multiple hours of a day in this sort of device, he was having increased work of breathing issues. While the respiratory therapist did come see him later that day, the first person that came to see him was the physical therapist, who was right out in the hall and was able to measure this person and let them try out a more appropriate power wheelchair that provided appropriate support for his torso, arm support for his arms, and foot support for his feet. So getting him into an appropriate seating and mobility device actually decreased his work of breathing. What about the speech therapist? We know that it takes an awful lot of energy to talk, especially when the bulbar component is increasing or your voice is becoming lower and lower. You have to use more and more energy to get the same volume. The speech therapist can assist you with some tricks of the trade, so to speak, on how you can keep your voice as loud as possible, utilizing different techniques of breathing, or minimize the amount of energy you're using in speaking, and tips on safe swallowing so that you don't have the issue of aspirating or having things go down the wrong pipe. Use equipment that you have available to you early on so you can spend your energy doing what you prefer. Is it talking or is it breathing? I actually ran across a gentleman that canceled his respiratory therapist appointment because he thought it was much more important for him to be able to talk and wanted to see his speech therapist. So depending on what's more important for you, please know that there is an overlap here. With regard to your nutrition, again, another key component. If you are having difficulty swallowing safely, we're going to start seeing decreased weight, which is going to lead to your mask not fitting appropriately, which is going to lead to fewer calories. And we already know that people with ALS are spending more calories to do the very same activities than people without ALS. So it's really important to make sure that you have adequate nutrition. Work hand in hand with your dietitian and respiratory therapist to make sure that you're monitoring your nutrition status. And if you so desire, you're looking at accessing that peg tube or that feeding tube sooner than later. The more you support your nutrition and caloric intake, the more energy you are going to have to spend on breathing. In addition to that, the nutritionist and dietitian can also provide tips so that you can decrease your risk of choking or chewing and swallow safely. Home care. You know, it's interesting, people with ALS have so many different challenges. When you think of someone who may have a challenge walking or talking or eating or even breathing, certainly potentially all of these things at once, you would think these people live in an ICU. But the reality is people with ALS live at home. They want to enjoy their home care setting. They want to enjoy their quality of life. They really want to maximize their quality of life. And the key to that is to make sure that you have a strong home care partnership. It really is critical to make sure that your home care provider, whether that's a PT, an OT, an SLP visiting you, providing skilled care, or your home care respiratory therapist, is aware of any changes that you may exhibit or being experiencing. Because a lot can happen between clinic visits. I know just last year in January, everyone was in clinic, and then COVID happened upon us and no one was in clinic as April and May and June of 2020 rolled around. So make sure that you have a good open communication with your home care team, and your home care team has that open with your clinic team. Looking at multidisciplinary care, we know that research supports people that attend a multidisciplinary clinic survive longer. And part of that may be due to the overlapping support they have. We know that positioning is important, nutrition is important, speech is important. But what happens if you have to leave your home to go to the emergency department? People with ALS can still have heart issues. They can still have an attack, a gallbladder attack. They can have any number of things. Can someone with ALS, whether it's related to ALS or another health issue. It's really important if you visit the emergency department to make sure that your team know key important factors about ALS, positioning and making sure you're able to sit upright rather than laying down. Respiratory evaluation. Oftentimes when people go into the emergency department and their oxygen saturations are low, oxygen is the first thing administered. Not saying that oxygen may not be needed, but it's critical to make sure that they're evaluating both your oxygenation status as well as your ventilation status, because it may be that you need your ventilation status addressed directly, and then your oxygenation status will follow. Advanced directives are always important. We know ALS is a progressive disease, but I can share with you advanced directives are important for anyone, regardless of whether they have a diagnosis of ALS or not. We always want to make sure that we're prepared about making sure our wishes for healthcare are known to our loved ones and to our healthcare team. Another key factor in emergency room care is always having rapid access communication, regardless of whether you currently use a communication device or not. I can tell you that I've accompanied family members and friends to the emergency room on a number of occasions the past several years, and I'm amazed that even the emergency department does not have a letterboard so that people can communicate. And that's a real challenge during an emergency. In addition to having rapid access communication, caregivers are always a key asset in an emergency department, especially for people that have ALS. So make sure your caregivers are well prepared for you as you go to the emergency department. Multidisciplinary care is certainly a foundation of ALS care, and included in that, or a component of that, is hospice care. Hospice care is really the most frequently chosen plan of care for people with terminal illnesses. And I underscore here chosen and care, because hospice services are not giving up or giving in. Hospice services are a plan of care to support you and your family and the quality of life that you decide that you want. It is just provided in venue, your home, or even hospice facilities. Oftentimes these go underused. So I would encourage you to be open to investigating the features and benefits of hospice care. I am not encouraging you to choose one form of care over another. I'm simply sharing with you that it's hugely valuable to investigate what the features and benefits are so that you can make a decision about how you want to incorporate or not any provisions of available care for you and your family. I know that oftentimes people are concerned about accessing ventilatory devices because they may feel like, if I access a ventilation device, I'm not going to be admitted to hospice services. Or some hospices may initially decline access or admission to people that are using ventilators or ventilatory support devices. I encourage you to have a conversation with the hospice and with your multidisciplinary team, because most often we're able to, with hospice officials, the use of respiratory devices does not change the course of this disease. It does not cure ALS. It does support ventilation, and it absolutely supports quality of life. So I don't want you to be discouraged about either accessing respiratory support or hospice services because of the unknown. Certainly worth a conversation with hospice organizations and your multidisciplinary team. In rounding things out, I can share with you that we covered a wide variety of things. We talked about how ALS impacts the respiratory system, adequate ventilation, and importantly, maintaining airway clearance. We talked about how the other disciplines, the physical therapists and speech therapists and nutritionists, their work also impacts your ability to breathe, without having to exert energy, and the value of that multidisciplinary team. The key here is ALS impacts a wide variety of things. However, these challenges can be addressed in a wide variety of options. Your multidisciplinary team are key to helping you figure out which items are going to be primary and which may be secondary, but all of them supporting the quality of life and the healthcare plan that you take the lead with. The other thing is your treatment. Investigate what all the options are so that you can select the options in the treatment that are going to be most applicable for your life, for your faith, for your finances, for your family. And then I really urge you is to keep your eye on the quality of life that you desire. This is your movie, this is your life, that of your family. ALS impacts people in a variety of ways and in a variety of times. So evaluate how your disease and your journey is unfolding. Reach out to your team and your family members and develop a program that's going to support your goals, what you want for your quality of life. If you have any questions, you are welcome to submit them in the chat box or submit them directly to me. My email address is here and my telephone number is also on the screen. Connie and Grant, I think I wrapped up in under the allocated time. I do not have access to the chat box on my screen. Are there any questions that I can answer?
So we haven't had any questions come across the chat screen yet. And maybe just a couple minutes of processing the presentation, we may have a couple pop up. But in the meantime, I did want to remind folks that through the ALS Association, so either myself or Shauna, as your care coordinators for families registered for association services, and assuming all of you, since you've all received this link and are participating in our webinar, but we do have the state advanced directives forms that Cynthia was talking about, the Indiana Living Will, the Indiana Healthcare Representative form. And then we also have copies of what's referred to oftentimes with medical providers as the POST form, which is a physician ordered scope of treatment. I have electronic copies of that, not because we can complete those with families, but because they would be a good guide when you're going in to meet with your clinic team or your physician and have the physician help to direct conversation in completing that form so that, as Cynthia said, this is your movie, this is your life, this is your control, and it will help to guide your team if you do have to go to the hospital to what your wishes are. And then as far as the simple communication board that Cynthia was talking about, that most emergency rooms don't have, and having 21 years of experience in a hospital, I can tell you it typically is a well-intentioned speech therapist running around trying to dig out of a file a communication board to allow somebody to have their say in their care. So along with the advanced directives, we also have what was sent to us through the national office called a file for life. And on that, it's a magnet, plastic magnet that can be attached to your refrigerator, or it can also be taken with you where there's a simple communication, a simple alphabet board on it. And there's also information in there about medications you take, medication about oxygen, just some key things that your emergency room team might find helpful immediately when you have to present in an emergency situation and your family may or may not be able to be with you at that same time. So those two things. And then, so in the meantime, we did get a couple questions. And the first one was, is this level of respiratory support available for individuals who elect to not seek out care at a specialty clinic? And she says, I am not familiar with how local neurologists or primary care physicians coordinate with respiratory therapists in an outpatient setting. Maybe it is a common practice. And this is coming from an individual who works in an outpatient rehab setting. So is this available to individuals not in the clinic setting?
Certainly, the physicians can place an order with a home care company for a bi-level device or for a non-invasive ventilator. Typically, these are pulmonologists or pulmonary physicians. If you are seeing a neurologist outside of a multidisciplinary clinic, they may refer you to a pulmonary physician because they have more expertise in the nuances of respiratory care and support. And that pulmonary physician would connect with a home care company, a respiratory care company, to place the order for the bi-level device with a non-invasive ventilator. And then the respiratory therapist will come to your home with the appropriate equipment and make sure that the equipment is set up appropriately, that you have the appropriate equipment, and then revisit you. This is not something that's just dropped off and you never see the respiratory therapist again. Again, it's important because of the nature of the equipment, as well as the fact that we know ALS is a progressive disease, and we want to make sure that as the disease unfolds, the equipment is being adapted to make sure that it provides you with the most adequate ventilation support necessary. So yes, physicians can order this. It is typically done by a pulmonary physician or respiratory specialist.
And the other part of this, Cynthia, might be that I know when I worked in hospital and I worked specifically with ventilator patients, oftentimes there was this perception that if you had a tracheostomy and had invasive ventilation, that you were connected to a machine that was connected by power cord to a wall outlet. And so maybe, and the question coming from a rehab setting or an outpatient setting, Grant, maybe you can touch a little bit about portability, because a lot of the pictures that Cynthia had showed those patients in a power wheelchair with the ventilation with them.
So a lot of those units do have a battery, but it is a limited life on how long the battery will last when it's not plugged in. On the power chairs, you can request to have what's called a power inverter, and it will actually convert the power from that uses to drive the chairs and operate the seating systems. It will also help extend the battery life of the if they're on a laptop vent or if they're on the Trilogy or something, we can get those. So the battery can be extended. And there also are devices so you can actually mount those to the back of the power chair so that way it can travel without any fear of cords or anything getting in the way for the patient as they maneuver throughout their home or their environment.
Oh, Grant, thanks so much for addressing that. And that's another thing I wanted to mention about the overlap between the different disciplines is quantum rehab is when you order your chair, if you know that you're going to be using respiratory support devices, they can actually configure that chair to have a vent tray on the back of it so it can be built to accommodate that for you. And again, you can either use the batteries that are hot swappable and available. There's also the option of wiring that directly into your chair, although the hot swappable batteries seem to be the most prevalent and recommended. But you don't have to be concerned if your usual weekend includes going down to the soccer field to watch your daughter play soccer. If you so choose, and you already have your power wheelchair and communication device, whether or not you have a peg or not, you can certainly utilize respiratory support either non-invasively or invasively and go down to watch your daughter play soccer on Saturday afternoon. Again, a lot of it is pre-planning, knowing what options are available to you, what options are going to fit into your lifestyle for your quality of life. But technology has definitely decreased the size of the ventilators themselves, increased the battery life, and thanks to folks like Quantum, able to put a vent tray right on the back of your wheelchair.
Thank you. Another question came in. What are some of the signs or symptoms of respiratory distress, and what do you do as a caregiver to help?
Well, that's a great question. And, interestingly, some of the signs kind of creep up on you because due to the progressive nature of ALS and how things sometimes change slowly, the person with ALS or their primary caregiver may not recognize that their work of breathing is increasing or that they're slowly breathing in a smaller and smaller volume of air to the point where it's not adequately ventilating them physiologically. Some symptoms that indicate someone may not be breathing adequately are dizziness, fogginess, headaches in the morning, things of that nature. Those are things that may indicate your CO2 or carbon dioxide levels are increasing, because as we decrease the amount of air we're breathing in and out, our body's still creating carbon dioxide and has to be released. So if our ventilation goes down, we're not able to expel that CO2 as easily, and that CO2 or carbon dioxide level builds up. So that's one indication. If you're having morning headaches, if you're feeling a little dizzy or a little groggy, if you're not sleeping well at night and you find that you're waking up frequently during the night. Another issue with regard to safe swallowing is if you are frequently choking on whether you're eating food or swallowing fluids, that overt choking or things going down the wrong pipe is an issue, but also because our bodies tend to create saliva that we swallow without thinking about it all the time. Silent aspiration often occurs whereby saliva goes down the wrong pipe without us realizing it, and then we end up with a pneumonia. So it's really important to make sure that we're breathing adequately. That may even include some respiratory exercises that your respiratory therapist or physical therapist may provide instructions for you to do. Also noting those choking or coughing episodes and your sleep quality and how you feel in the morning when you wake up. If you do have any overt choking, of course, the Heimlich maneuver has been around for many, many years. That is helpful. You can always also call your EMS if you're having a all of a sudden issue with choking that you're not able to get food or something out of airway.
Wonderful. Another question, is it common practice for patients in clinic to be prescribed with inspiratory muscle trainers in early stages of ALS?
That's a good question. There have been a number of studies looking at exercise in general and exercise with regard to inspiratory trainers or respiratory exercises. There was a recent article, it's actually out of the University of Florida. Speech language pathologist is doing research on some respiratory exercises. What I can say is, and I can certainly get back with you, Connie, on and link to that so that you can post it to your website. But it's really important to make sure that we are taking a deep breath. We tend to sigh multiple times a day without thinking about it. So our body's already pre-wired to, I breathe in and out a quart of air every time I breathe. But then a couple times an hour, my body just takes a deeper breath. If you have ALS, your body may not be able to do that, and your respiratory night is going to be decreased. So it's important to exercise. When I say exercise, I mean proactively take some deep breaths to keep those air sacs at the bases of your lungs open. And that also helps you cough easier. Remember, the first phase of a cough is the ability to take a deep breath. So if part of your inspiratory exercises include something like breath stacking or taking multiple breaths without exhaling, that does two things. It increases your alveolar ventilation or provides ventilation to the air sacs at the bases of your lungs, and it also enables you to help clear your airway. But Connie, I will get that article to you so that you can use that as a resource.
Okay, thank you. And this one kind of goes along with that. Can the regular use of BiPAP and cough assist devices extend the quality of life?
think research shows that it definitely can extend your quality of life. We know that attending multidisciplinary clinics certainly does support longevity. And if you are having ventilation issues, we know that addressing those respiratory needs is critical in order to support your longevity. That's longevity without considering quality of life. In addition to longevity, respiratory support devices or ventilation devices can certainly impact the quality of life because you determine what your quality of life is. You determine where you are going to live, who is going to care for you, the type of equipment or technology that you're going to use. Some people simply choose not to take advantage of complex mobility devices or feeding tubes or communication or respiratory devices. Other folks include a variety of those things within their range. And some people say, I'd like to take advantage of everything. So it really depends. And I can quickly share with you because we have just a couple minutes left. This occurred a couple of years ago. I talked with people across the country, and it was really interesting because I had the same conversation with two different people that lived in totally different states within the same week of each other. And one family was sharing with me that they felt life was a gift from God, and because of that, they were okay with this disease not having a cure. And because they felt life was a gift from God, they were okay with having the disease unfold and accepting that in their family and as their treatment plan. A few days later, another family in different states said almost the same thing, but they had a different outcome. They said, well, we believe life is a gift from God, and because of that, we're obligated to utilize, everything, every piece of equipment or technology that we have access to support that. So they decided to move forward with the technology that was available to them. So you can see both of these families started out with the same idea that they felt life was a gift, but the way they viewed it based on their perspective provided totally different outcomes. So please investigate how ALS is impacting you. Understand how ALS is impacting you, particularly how it is unfolding for you, for your journey, and then seek out the options that you have available to you from your multidisciplinary team, or if you're getting your care from an outpatient clinic or the community from your healthcare providers. Investigate all those options and then develop a plan that's going to work for you. I know that the advent of technology has really increased over particularly the past 10 or 15 years. And so a lot of new things are available to people that weren't before. But it's your choice. It's your team, it's your treatment decision, and it's your quality of life.
Perfect story. Perfect story. And I think that we've answered all the questions in the chat, and a choice, there's always a choice in healthcare. There's choice with equipment companies, respiratory equipment companies. Just make sure that you've done your research, talk to your clinic team, ask for recommendations to make sure that you know what it is that that is being ordered on your behalf, and that you get the training and that to use it properly and safely. So that was a reminder that came in. And I think we got everybody. So I think, Grant, we're ready to sign out. Oh, you're on mute.
Looks like that concludes our presentation. On behalf of Quantum and the ALS Association of Indiana chapter, I would like to thank everyone for joining us. Save the date for Thursday, July 29th at 2 p.m. as our featured guest will be Dr. Caldup Davey, Vice President of Research for the ALS Association. He will share updates on the ALS Associated funded research projects across the globe. Come ready with your questions. For more information about the golf outing, walk events, program services, support groups, or this webinar, please visit visit at alsindiana.org. So thank you everybody for attending. Cynthia, thank you for your presentation, and look forward to everybody next month.
Thank you. And we will post this to our chapter website along with Cynthia's information that she shared with us this afternoon. Thank you, guys.
Thank you.